Welcome to AETCM, the emergency medicine channel. Today let us discuss about one important arthropod-borne infection, that is chikungunya. It is chikungunya, not chikungunya. It is nothing to do with chicken or chicken pox. This is an insect-borne virus of genus alpha virus. It's an arbovirus. It is transmitted through Aedes mosquitoes. It causes various symptoms like fever, joint pains, neurological problem, liver disease, myocarditis. So many complications can be produced by this virus, but normally it produces mild fever and subsides without any major treatment. There are two important mosquitoes can spread this disease. One is Aedes aegypti. You can see the first mosquito. Other one is Asian tiger mosquito. You can see the second mosquito. The same mosquito which transmits dengue fever also. That's tiger mosquito. Normal incubation period is 2 to 7 days. Most of these patients, 85% of these patients can have high degree fever initially. Just 7 days or 7 to 10 days they can have fever. Some patients can have muscle pain, joint pain. Very rarely these patients can progress to prolonged arthritis, especially ankle joint. That is a very classical finding seen in chikungunya. Many patients can have ankle joint arthritis after chikungunya. So this chikungunya arthritis is very common in endemic areas of chikungunya. When you track patients who is having chikungunya, only very few have this arthritis, prolonged arthritis. But in an endemic area, you can see large number of patients who is having chikungunya arthritis. Half of the patients can have skin rashes. In many of the patients who is having chikungunya, they can have initial small blebs or bumps, palms, foot, soles, face, all those areas they can have rashes. Rashes remain initially to the small part of the body, then it can become extensive and it may cover 90% of the body surface area. Some patients can have GI issues like abdominal pain, vomiting, diarrhea. These all are seen in dengue fever also. So the clinical findings may be almost similar to dengue fever, except for high grade bone pain. That is a classical for dengue fever. And here patients can have arthritis. That is not seen in dengue fever. Many patients can have severe eye problem. They can have sensitivity to light, painful eyes, conjunctivitis. All these things are also seen in dengue fever. Pruritic rashes are very common in many patients who is having chikungunya. And post chikungunya, that is very important striking feature, hyperpigmentation, darkening of skin. This is seen in many viral illnesses, many bacterial infection also. You can see many patients discharged from ICU, they have similar complaints. They have darkening of skin, they have loss of hair. So many skin and hair related problems can be there in this type of viral infections. Nikolsky sign is seen in many patients after rubbing the skin lesions. You can see the skin layers are removed or slip away of skin layers can be seen in many patients. Now some patients go to the chronic phase of the disease. Some patients can have post-acute phase of this disease. The symptoms may last for 3 to 4 months. Then chronic stages may remain many months, many years also it can remain. So arthritis and all, it will be like rheumatoid arthritis for many years. Patient can have similar finding and exacerbations. So chikungunya, the word meaning of chikungunya means that which bends up. That means patient can have severe joint pains and they become forward bending because of the joint pains, especially in the lower limbs and sacroiliac joints. Joint pains are there in many patients who can have joint pains, especially in the lower limb arthritis is very common, and ankle joint arthritis is very classical. Some patients can have neurological complication like any other viral fever. There will be some amount of immune mediated destruction of neurological tissues or nerve covering, like myelin sheath covering can be destroyed. Patient may develop encephalopathy, encephalomyelitis, myelitis, GBS, acute disseminated encephalomyelitis, inflammatory ocular disease, retinal detachment. So many neurological complications may occur. It is not a classical finding seen in all type of these chikungunya cases. Very rarely some patients may go to this type of immune mediated disorders. In that very classical finding is Guillain-Barré syndrome. This Guillain-Barré syndrome is explained in many viral diseases including chikungunya. It is not directly produced by the chikungunya. It is produced by the antibodies against chikungunya which act against our neuronal cells. Now, when we take the lab investigation, classically most of the viral fevers can have some low WBC count. Neutropenia can be there, lymphopenia can be there, thrombocytopenia can be there, liver enzymes can be elevated in many patients. Viral cultures are not very common. That is not done in many local laboratories. Only in biosafety level 3 laboratories can do all these things. We can do chikungunya IgM or IgG. Detectable from 5 days to months after the onset of symptoms. We routinely do chikungunya IgM. RT-PCR can be done in patients who is having suspected chikungunya. So RT-PCR also will be positive in many chikungunya cases. It's one of the best investigations if it is available. Now, when we talk about the management, there is limited role for managing these patients with antiviral drugs. Routinely we give paracetamol, IV fluids, multivitamins. Steroids has got some role in arthritis, like any other arthritis, rheumatoid arthritis or any inflammatory mediated arthritis. We start steroids, and once the steroid reduces the inflammation, we add methotrexate or hydroxychloroquine sulfate. Here also what we should understand is it is an immune mediated destruction of the joint. Like rheumatoid arthritis mainly affects the upper limb joints, but here it affects mainly the lower limb joints. So we have to start some drug to prevent the destruction of joint. That steroids will take care initially. Then once the steroids reduces the acute inflammation, we have to add methotrexate or hydroxychloroquine sulfate. Methotrexate can be started in 25 mg per week with folic acid. Slowly reduce the dose of methotrexate to 7.5 mg in a week with folic acid. Always it should be given with folic acid, and at least every month we have to check the WBC count because it can produce neutropenia. We have to see the LFT, it can produce LFT alteration. We have to see the creatinine. So these 3 investigations should be done every month, and methotrexate can be continued. Hydroxychloroquine can be continued, but only thing we have to see the retinal examination every 6 months for looking for any retinal pigmentation, blackening of retina. And some patients who are on hydroxychloroquine, when they are exposed to sunlight, they can have darkening of skin. So sunscreens must be given along with hydroxychloroquine sulfate. Eye checkup has to be done. And some vaccination protocol is under development. At present it is not available in our country. So we have discussed about one important arthropod borne disease or vector borne disease or mosquito borne disease, that is chikungunya. It is very common in our country. It can produce permanent joint destruction, especially lower limb, especially ankle joint destruction. That produces a lot of disability in patients. So to prevent that, this is a one viral infection where we can use safely steroids and steroid-sparing anti-rheumatoid drugs like methotrexate or hydroxychloroquine sulfate. Thank you.